So today we're very lucky to have with us Magdalena Cerdá, who is a professor and founding director of the Center for Opioid Epidemiology and Policy in the Department of Population Health at NYU Grossman School of Medicine. Her research focuses primarily on two great challenges to improving population health and health equity: substance use and violence. Specifically, her work addresses the social and policy determinants of substance use from childhood to adulthood, and the causes, consequences, and prevention of violence. In her most recent work, she has applied methods from epidemiology, statistics, econometrics, and computer science to answer important questions about the impact the interventions at the local, city, state, and national level can have on overdose and violence. Dr. Cerdá chairs an expert review group for the United States National Academy of Medicine Opioid Collaborative on integrating a social determinants of health lens into approaches to address the opioids crisis. She also serves as senior editor of the International Journal of Drug Policy and has authored or co-authored over 250 peer-reviewed publications and 5 book chapters. So very busy, and we're very glad that you're with us today. So Dr. Cerdá, over to you.
Thank you. Thank you so much, everybody, for being here today. So I'm going to give an overview of what our team's work on the U.S. overdose crisis, looking at some successes and unintended consequences of policy measures. Just as disclosures, my work is funded by National Institute on Drug Abuse, the Robert Wood Johnson Foundation, and the Centers for Disease Control and Prevention. And I also serve as an expert witness in opioid litigation case in the United States. So today I thought I'd first start by just giving you an idea of what the trends in overdose have been in the United States in the past 30 years, some of our hypotheses about potential drivers of this overdose crisis, what we found about the impact of leading opioid policy responses on overdose, and then really going from there to look particularly at cannabis as a potential substitute for opioids, in response really to a question that I always get about, well, what about cannabis? What about cannabis legalization? Could that be a potential solution to the overdose crisis? And then conclude. So unfortunately, the United States has the very dubious distinction of being a leader in terms of opioid overdose mortality in the world. This is a graph showing you the deaths per million population from 2000 to 2020 in different countries, some of the countries with the highest rates of opiate overdose across the world. And you can see that the United States is has far and above the highest rates, and it actually is only increasing. And since COVID, it has increased even more. This figure shows you a timeline of the waves of what we call the overdose crisis. So we started to see a rise in overdose deaths. The black line denotes any overdoses involving any opioid. I'm going to start by talking about the first wave, which is the light blue line. And so first we saw a rise in overdoses involving prescription opioids. And really, that was driven a lot by the proliferation of the use of opioids to treat chronic non-cancer pain. And I'm going to get into that in a little bit. After those rates rose, they started to stabilize around 2010, still at much higher rates, but stabilizing relative to the prior time period. But as we saw rates from prescription opioids stabilize, we saw a rise in overdoses involving heroin. And so that's the dark blue line that you see here. And that's really the second wave, where we saw a shift in overdoses from prescription opioids to heroin. And here there's a concern about whether a lot of the measures that tried to tighten up the prescription opioid supply led people who had become dependent on prescription opioids to shift to the illegal market. After we saw a rise in heroin overdose deaths, again, we started to see a stabilization of heroin overdoses, but that took us to the third wave, that's in the purple line. where we saw a rise in synthetic opioid overdoses. And so really here we're talking primarily about fentanyl and other illegally manufactured synthetic opioids. And that was really due to the introduction of fentanyl into the illegal drug market. Fentanyl is highly potent, highly lethal. Right now, we are in the fourth wave, where it's still primarily driven by illegally manufactured synthetics, but it's starting to take a different character, which is really the combination of opioids with other drugs, primarily with stimulants. And so in this fourth wave, which is shown in the red line, we're seeing a rise in particularly psychostimulants, and so methamphetamines and cocaine in combination with opioids. So opioid overdose doesn't affect everyone in the same way. And so we've seen a real marked difference in opioid overdose death rates by race, ethnicity. When the overdose crisis, this version of the overdose crisis started in the late 1990s, it was primarily involved American Indian and Alaska Natives, that's the purple line, as well as white Americans in the red line. However, in the past, I would say 10 years, we've seen a marked rise in overdoses among racially minoritized groups, particularly among Hispanics and Black Americans. And today, if we stretch this timeline further to more current times, we'll see that overdoses involving Black Americans have actually surpassed those of whites. So now the most affected groups are American Indian, Alaska Natives, and Black Americans. We had started to see a stabilization and possibly a decline in overdoses before the start of the COVID-19 pandemic, so in 2019, but that really changed with COVID. And so this is a graph showing you the monthly drug overdose deaths, all overdoses in blue, opioid overdoses in green, and synthetic opioids in orange. And so you can see dates both before and after the start of COVID. And so what you can see is that really there was a marked rise in overdoses at the start of the pandemic. Now, they went down after, I would say, after May 2020, but you can see that the numbers are still higher than they were before the start of the pandemic. In fact, in 2021, data shows that more than 100,000 people died of an overdose, primarily involving opioids, and that was the highest number ever recorded in US history. Right now, as I mentioned before, the idea is that we're in this polydrug use crisis, where it's primarily driven, primarily involves opioids, but opioids in combination often with stimulants. And so we looked at the trends in overdoses involving opioids and stimulants across US states by race. And so here I'm showing you the estimated combined opioid and cocaine mortality rates. In the top row among whites in 2007 and in 2019, and then the bottom row among Blacks, again in 2007 and in 2019. And so you can see the darker shades denote higher rates. And so you can see that for both Blacks and whites, there was an increase in overdoses involving opioids and cocaine combined. It was really primarily concentrated in the East Coast of the country, but the rise was much higher among Black Americans compared to white Americans. In fact, there was almost a 600% increase among Blacks compared to almost a 200% increase among whites. We also looked at the same kind of phenomenon, but now looking at combined opioids with methamphetamines. another type of stimulant. And again, here I'm showing you the results for whites and for blacks in 2007 versus 2019. And so you can see, again, huge increase across the whole country in both whites and blacks. It started out and really primarily concentrated in the West Coast. So these different combinations have really interesting geographic patterns where cocaine is more located in the east, methamphetamines more in the west. But again, the rise was much higher among Black Americans compared to white Americans. So this really, for me, it's a really striking finding, the increasing rates of overdose among racially minoritized groups, because a lot of the discussion around the overdose crisis really is still stuck in the 1990s, where it affected particularly rural, suburban, exurban white Americans. And so a lot of the language and a lot of the ideas about causes is really still focused on that. But now we're seeing a huge shift in the types of populations that are affected by this crisis. And so I think that really calls to attention the need to shift our framework about what might be driving these overdoses. Okay, so that takes us to the second question. Now that we've talked a little bit about, giving you a little bit of an idea of where we are with this problem and how it's spread across the country and who it's affecting, the second question I think that's important is, well, what contributed to the rise in opiate overdose deaths? And so the root of this current crisis really started in the 1990s with the proliferation, as I mentioned before, of opioid prescribing. And really, so up until then, opioids had really been used more for cancer, for end-of-life care, for acute pain in small amounts. But in the 1990s, there was this shift among professional pain societies and the pharmaceutical industry, often in concert, to, first of all, to think about pain as the fifth vital sign, and second, to push for opioids to be considered as a safe, humane, non-addictive alternative for treating chronic non-cancer pain. And so that push really led to the proliferation of the use of prescription opioids among patients with chronic pain. And so that you can see here in the black line, almost a 400% increase in opiate prescribing. And that increase in opiate prescribing was followed shortly thereafter by a rise in overdoses involving prescription opioids. So that really drove a lot of the trends in prescription in the first wave. Pharmaceutical industry practices seem to play an important role in driving opiate shifts in opiate prescribing and overdose. In a paper we published a couple of years ago, we looked at the data on the monthly physician payments per capita, payments by the pharmaceutical industry to physicians related to marketing of opioids. And so that could be anything from a sizable honorarium to a lunch. So a very small value transfer to very high value transfer. And so here you can see the distribution of monthly payments by the pharmaceutical industry around opioid marketing across the country by county. And then 1 year later, here again, you can see the distribution of prescription opioid overdose death rates. And so you can see just by looking descriptively that there does seem to be a spatial overlap in counties where there were higher rates of marketing to physicians around opioids. There was a subsequent higher rate of prescription opioid overdose deaths. Of course, that's only descriptive, but so we actually did look at the data with models looking at the relationship between changes in opioid marketing by the pharmaceutical industry to physicians and subsequent changes in overdose death rates. We found that there was about $40 million invested in opiate marketing that targeted about 67,000 physicians. This is starting to look in the 2013-2015 period, but this continued thereafter. And with our data, we found that indeed an increase in county level marketing of opioids was associated with a rise in overdose mortality a year later. And part of this effect, part of this relationship between pharmaceutical industry marketing and overdose deaths was really mediated by an increase in opioid prescribing. That is, in counties where the pharmaceutical industry seemed to target more physicians, there was a subsequent rise in opioid prescribing, and also then a rise in prescription opioid overdose deaths. One thing that we've found really interesting about this study is that what seemed to matter was not so much how much physicians were paid, but the number of interactions that physicians had with the pharmaceutical industry. And it was often these low-value transfers, like a coffee or a lunch. And so that to us suggests that it's more about establishment of trust in the pharmaceutical industry rather than high value payments. And so again, I think results like this have really led to much greater regulation by health systems, by states, on the types of interactions that the pharmaceutical industry can have with physicians around the topic of opioids. So that really referred to the first wave of the epidemic. But then, as I mentioned before, the rates of overdoses involving prescription opioids stabilized, and we moved to the second wave, right? And so the second wave was characterized by a rise in overdoses involving heroin and a shift to the illegal market. And so what happened there? What do we think happened? Well, we think that there was a particularly concentrated rise in heroin use among people who had previously used prescription opioids. And so one of our hypotheses is that when we saw overdoses involving prescription opioids rise, the federal government and state and local governments enacted a series of different measures to try to regulate opioid prescribing. And so that made it much harder to access prescription opioids. But there were also at the same time a lot of people who had become addicted to opioids. And that coincided with a decline in the cost of heroin and an increase in the supply of heroin. And so those two forces likely combined, the restriction in the prescription opioid supply and the increase in both in the supply, in the purity, and the decline in price in heroin to contribute to a rise in the use of heroin and a rise in overdoses involving heroin. After that, we saw, as I mentioned before, what we think is the third wave, which included heroin, but was more increasingly driven by synthetic opioids. And that really started in 2013 with the introduction of fentanyl into the East Coast drug markets. What's really notable about fentanyl is that it's much cheaper than heroin, and it's 30 to 40 times stronger. So it's much more lethal. And so really with the flooding of fentanyl into the drug markets, that really shaped the third, and I would say the current wave of the epidemic. To the point now where, for example, in New York City, where I'm located, when people think that they're consuming heroin, it's likely not heroin. It's mostly fentanyl. Fentanyl has really taken over. And we think that that's also driving partly the fourth wave, which is this combined stimulant and opioid wave, because partly intentional co-use of stimulants with opioids, but partly it's because people think that they're consuming cocaine or methamphetamines, but they're actually also consuming fentanyl because it has penetrated much more widely into the overall drug supply. Okay, so now that I've talked about some of the trends in the overdose crisis and what some of our hypotheses about what may have driven the evolution of the overdose crisis up to the present time, I think for me, one of the really interesting questions to answer as an epidemiologist is about, what can we do about it, right? And so as an epidemiologist, I think about evaluating the impact of existing policy responses. And so what role have leading policy responses played in the opioid overdose crisis? So I would say that up to the current time, there have been three leading types of responses that the US federal, state, and local governments have taken to address this issue. First, there's a predominant response around regulating the prescription opioid supply. And so that involves a wide range of things, from prescribing guidelines published by the National Centers for Disease Control and Prevention, to placing limits on initial prescriptions, to what I'm going to talk about a little bit, which is regulation of pain clinics. The second type of leading response is really around preventing overdoses and really preventing death from overdoses. So this is around harm reduction. And so this could involve the distribution of naloxone to reverse overdoses, can involve encouraging people to call for help when they witness an overdose. They can involve the distribution of clean syringes, among other responses. And then third, and increasingly, there's been a real focus on increasing access to evidence-based treatment for opioid use disorder. And here, when I talk about evidence-based treatment, I really mean medication to treat opioid use disorder, primarily methadone and buprenorphine, and then to a lesser extent, naltrexone. So one of the really interesting things for me is not only to evaluate what the intended effects could be of these different policy responses, but also to think about what might be some of the unintended consequences of these policy responses. And so here I'm really talking about this issue that I mentioned before around the tightening of the prescription opioid supply. So this graph shows you in the blue bars, it shows you the opioids prescribed in morphine milligram equivalents over time. And so you can see that there was first a rise in opioid prescribing, but then as we saw a rise in prescription opioid overdose deaths, which is in the red line, opioid prescribing declined. And that led to the stabilization of prescription opioid overdose deaths. We could call that potentially a success of policy measures that regulated opioid prescribing. But as I mentioned before, we also saw a rise in overdoses involving heroin in green and other synthetic opioids in blue. And so that calls to mind, well, could there have been an unintended consequence of these policies that regulated the prescription opioid supply? And could making prescription opioids less available without accompanying investment in alternatives in demand reduction, could that have contributed to a rise in overdoses involving illegal opioids? And so I'm going to talk about a little bit of that in the studies that I'm going to showcase today. So we've done research evaluating the impact of leading policy responses in all of these three areas. But in the interest of time, I thought I'd talk about one example for each. And I'm happy to talk about other policy responses in the Q&A. So for regulation of the opioid supply, I'm going to talk about pain management clinic laws. For overdose prevention, I'm going to talk about Good Samaritan Laws. And for access to treatment, I'm going to talk about Medicaid expansion. So first of all, focusing on pain management clinic laws. So what are pain management clinics? So these are spread out obviously across the country, and they're clinics where patients go to have chronic pain treated. However, what happened, particularly in the first wave of the overdose crisis, is that some of these pain clinics, particularly in some states like Florida, were functioned as a key source of inappropriate high-volume opioid prescribing. Like, for example, what you can see here in this photo, providers in some pain management clinics prescribed and dispensed opioids without any clear medical need. In fact, without a medical exam, often in exchange for cash. And so what would happen is people would go to these clinics, they'd say they wanted opioids, they were prescribed opioids at a very high dose for a high duration. And there was often a pharmacy on site so that they could get the pills right there. And so what happened is people would drive to these clinics from all over the country that buy high volumes of opioids, and then they divert them to the illegal market. And so this functioned as a key source of flow of pills to the illegal market, and we think really contributed to the rise of overdoses involving prescription opioids. So one of the approaches to regulate this problem was the enactment of what are called pain management clinic laws. And so these laws are really trying to professionalize the work of these pain clinics and to prevent the inappropriate prescribing of opioids to people with no clear medical need and at much higher doses than actually needed. Different states enacted very different pain clinic laws. And so we were particularly interested in figuring out, first of all, to what extent did these pain clinic laws have an effect, first of all, in opioid prescribing, and second of all, in overdoses. But then we also wanted to figure out, well, what type of pain clinic laws were most effective. And so what I'm going to show you today is some of our findings for overall for any kind of pain clinic law, but then I'm also going to particularly focus on pain clinic laws with penalties for criminal penalties for non-compliance. And so what did we find? So here, first I'm showing you the effect of enactment of pain clinic laws on county level opioid prescribing. And I'm showing you two types of opioid prescribing that are considered to be very high risk. One is long duration, that is prescriptions for more than 30 days. And the second is high dose, that is for more than 90 MMEs. And so what you see is in the yellow lines, you can see the effect of any type of pain clinic law. And in the red line, you see the effect of pain clinic laws that placed a criminal penalty for non-compliance. And so you can see that any kind of pain clinic law, enactment of any kind of pain clinic law had a small effect in terms of long duration and high dose prescribing. But really what seemed to be most effective was these pain clinic laws with a criminal penalty. And those seem to have a sizable effect in terms of reducing this kind of high risk opioid prescribing. And so if you look at that, you think, great, this is a success, right? We really declined the high risk opioid prescribing with these laws, particularly with laws that have teeth. Then we looked at the effect of pain clinic laws on county level opioid overdose deaths. And we looked at overall, so we looked at three things here. In the left-hand side, you can see the effect of any pain clinic law and those with criminal penalties on overdoses involving any kind of opioid. Then moving more toward in the middle, you can see the effect on overdoses involving prescription opioids. And then finally on overdoses involving heroin. And so overall, particularly pain clinic laws with criminal penalty were associated with a decline in opioid overdose deaths. And that was really primarily driven by a decline in overdoses involving prescription opioids. So again, decline in high-risk opioid prescribing, decline in overall opioid overdoses, primarily driven by prescription opioids. All of that denotes great success of these laws. However, at the same time, we saw an increase in overdoses involving heroin. And so this really speaks to this potential for unintended consequences, right? So while our objective was achieved, we saw a decline in prescription opioid overdose deaths, we also saw a potential rise in heroin overdose deaths. And so that leads us to think about, well, what should have been enacted in concert with these pain clinic laws to be able to reduce this unintended consequence. The second type of approach I'm going to talk about is around overdose prevention. And so again, when we think about the unintended consequences of some of these policies that regulated the prescription opioid supply, we have to think about these partners, right? And the partners might be harm reduction and improved access to treatment. So what do we know so far about overdose prevention or harm reduction approaches? I'm going to talk about what we've found so far about Good Samaritan Laws, which is one of the leading types of policy responses enacted by states across the US. So what are Good Samaritan laws, or GSLs? So Good Samaritan laws are designed to protect bystanders who call for help in case of an overdose from being charged for a drug-related crime. So the issue is here, people may witness an overdose, but they may be afraid to call for help because they may be arrested or charged or prosecuted for possessing drugs or possessing drug paraphernalia. And so this law says, okay, if you call for help, then that will protect you against these charges. And so that's supposed to increase the rate of reporting and the speed of the response. And that could really prevent deaths from overdose. At this point, 45 states have some kind of Good Samaritan law. But again, the issue here is that states differ widely in the type of Good Samaritan laws that they've enacted. So some states protect bystanders from being arrested if they call for help, but others protect from being charged or prosecuted. And then finally, others have a mitigation on the charge or sentencing. And so you can imagine that one's likelihood to call for help might really differ depending on what the level of protection is. Right? So if you're going to be, your sentence is going to be mitigated, but you're still going to be arrested, you might be much less likely to call for help than if you're going to be protected from arrest. And this is particularly a concern, I think, for racially minoritized communities and immigrant communities. We looked at the impact of Good Samaritan laws in conjunction with naloxone access laws. These are laws that make naloxone more available just because they're often enacted simultaneously. And so in this study, we looked at the effect of Good Samaritan laws on county level overdose deaths. And so here I'm showing you two different types of outcomes. In the left-hand side, the impact of these laws on all opiate overdose deaths. And then on the right-hand side, their impact particularly on overdoses involving heroin and synthetics. And for each outcome, I'm showing you two types of laws. First of all, in the orange is Good Samaritan laws that protect you from being charged, but you can still be arrested. And then in the blue, you can see the Good Samaritan laws that protect you from being arrested. So here, what we find that's really interesting is that what seems to be effective is Good Samaritan laws that protect bystanders from being arrested. And what's really interesting here is that not only is there an overall effect in opiate overdose deaths, but there's a particular decline in overdoses involving illegal opioids. So again, calling to mind the need to pair these different types of policy responses together to really get at a decline in all types of opiate overdose deaths. Okay, and then that leads me to the third type of policy response that I think it's really important to pay attention to, particularly when we want to think about reducing the unintended consequences of shutting the supply. And that's really a policy response that tries to reduce demand for opioids. And here particularly, I'm focusing on improved access to treatment for opioid use disorder as a demand reduction alternative. So we know, but we have very strong evidence that using medication to treat opioid use disorder really works. So that involves both buprenorphine, methadone, and naltrexone. We know that use of medication can help patients cope with symptoms of withdrawal and relieve cravings for opioids. We've also seen that efforts to increase access to medication has reduced both levels of opiate misuse and hospitalizations. And these drugs have proven to be effective in a number of different randomized controlled trials. However, even though there's pretty strong evidence that treating opioid use disorder with medication works, access to medication is a huge challenge in the United States. This is data that we recently published where we looked at an estimate of all patients receiving some kind of medication for opioid use disorder. That's this line, the lowest line, number of individuals in the lowest line. And then we have an estimate from survey data of how many people actually have opioid use disorder. That's this second line. But then actually there's a huge under response. There's a huge bias in the survey data. So we adjusted for underestimation of opioid use disorder. And so our adjusted estimate of opioid use disorder, which is this top line here, you can see that there's a huge gap between the number of people who likely meet criteria for opioid use disorder on top and the number of people who are actually getting treatment for opioid use disorder. In fact, we found in this study that 87% of people with opioid use disorder do not receive treatment. That's a huge issue, right? If we're seeing people die every day from overdoses, and yet people who need treatment are not getting access to it. So in the United States, and I know this might be very striking in the UK, where you don't have the same healthcare access issues that we have, but in the United States, healthcare access is a huge issue. And so with the enactment of what was called the Affordable Care Act, one of the ways to increase access to health insurance, particularly for low-income individuals, was what's called Medicaid expansion. Medicaid is a form of health insurance for low-income populations. And so with Medicaid expansion, states were able to increase Medicaid coverage to nearly all adults with income at or below 138% of the federal poverty threshold. So that is for individuals that had an income of about $17,000 a year per individual. And so researchers have looked at the impact that Medicaid expansion, by increasing access to healthcare, what impact it had on access to treatment for opioid use disorder. And so, for example, in this paper published by Sharp et al., they compared trends in receipt of different types of medication to treat opioid use disorder, naltrexone, buprenorphine, and methadone, in states that expanded Medicaid in the left compared to those that did not expand Medicaid in the right. And so they did find that particularly for buprenorphine, there was a concerted rise in prescribing and use of buprenorphine to treat opioid use disorder after expansion of Medicaid. So that seemed to suggest that, again, increasing insurance coverage for low-income individuals increased access to treatment for opioid use disorder. So given these findings, we were interested in seeing whether by increasing access to treatment, whether Medicaid expansion could also reduce overdose deaths. And so in a study, we looked at the impact of Medicaid expansion on county level opioid overdose death rates. And we found indeed that Medicaid expansion was associated with a decline in any opioid overdose deaths. And that was primarily driven by a decline in overdoses involving heroin and synthetic opioids. So again, what we're seeing is regulation of opioid prescribing declines prescription opioid overdose deaths, but it might have this unintended impact on illegal opioids. But if you pair regulation of the prescription opioid supply with overdose prevention efforts and with increased access to treatment, you might be able to also decline overdoses involving illegal opioids. So it really calls to attention the need for a multi-part, multi-dimensional response to the problem that really targets the supply, it targets harm reduction, and it targets demand. So talking about demand, one of the I guess theories that has been pushed is the role of cannabis as a way to reduce demand for opioids. And the idea here is that could cannabis serve as a substitute for opioids? And in that way, could we partly address the overdose crisis by increasing access to cannabis? So what has been found so far about the role of cannabis in the overdose crisis? So there's moderate evidence that cannabis may be effective in managing chronic non-cancer pain. Some studies have found more than a 50% decrease in pain with the use of cannabis. a decrease in the intensity of pain, and an improvement in the quality of life. And so if we think about people using opioids to manage chronic non-cancer pain, and if we think that cannabis might be effective at treating chronic non-cancer pain, could people who would have been using opioids instead use cannabis, right? And so here the question is, well, could increased availability and access to cannabis lead people to substitute opioids for cannabis? That is, could it lead people who were using opioids to transition to cannabis? And could it lead people to initiate cannabis use and instead of initiating opioid use? So for me, as I do a lot of policy evaluation work, that led me to ask the question, well, then could increasing cannabis legalization, so we know legalizing cannabis increases access and availability to cannabis, so could cannabis legalization induce enough substitution of opioids with cannabis to shift population level rates of overdose, right? So if with legalization, increased access and use and increased use of cannabis, which we have seen, could that lead to a decline in opioid use? And could that lead to then a subsequent decline in opioid overdoses? So far, medical cannabis is legal in 39 states and Washington, D.C., and recreational cannabis is newly, as of 2 days ago, legal in 24 states. Prior evidence on the impact of cannabis legalization on overdoses is quite mixed. So some studies have found that medical and recreational cannabis laws were associated with a decline in opioid prescribing. But people who use cannabis medically may actually be more likely to use prescription drugs. So that's kind of a conflicting evidence. Further, in terms of its impact on overdoses, again, the evidence is mixed. There's some early studies that found a decline in opiate overdoses following legalization of medical cannabis, but others failed to find any effect, and yet others found an increase in overdoses, particularly in the more recent waves of the epidemic. So why is it that there's so much discrepancy in these findings? Well, I think part of it is that different studies define the exposure in different ways. Often they don't account for whether supply is actually available in the states. That is, states may have legalized cannabis, but they may not allow stores to sell cannabis. They may also not account for other confounding co-occurring policies and contexts. So the thing with evaluating the impact of cannabis legalization is that states have enacted so many things at the same time, right? So many laws at the same time that may be affecting overdose rates. And so it's hard to really identify and isolate the effect of cannabis legalization from these other co-occurring changes. And finally, there's huge variation within states in opiate overdoses over time, and states and evaluations have often just looked at the impact of legalization in average rates across the state, not accounting for this temporal and spatial heterogeneity within states. So we conducted a study to look at the particular impact that legalization of medical cannabis supply and recreational cannabis supply had at the state level, had on county level rates of opioid overdose, accounting for a range of different co-occurring policy responses targeting prescription opioids, targeting overdose prevention, and targeting access to treatment. And so what did we find? So what you see here in this table is the relationship between medical cannabis supply legalization and recreational cannabis supply legalization on two different types of outcomes. First, on these high-risk opioid prescribing patterns, that is long duration, more than 30 days, and high MME, more than 90 MMEs of opioid prescriptions. And then the impact of legalization on opioid overdose deaths for all opioids, for prescription opioids, for heroin, and synthetic opioids. And so what do we find? Well, medical cannabis supply legalization seemed to have a very small, associated with a very small decline in high-risk opioid prescribing, but also a small increase in overdoses involving opioids, particularly involving prescription opioids and synthetics. In contrast, recreational cannabis legalization seemed to have no impact in opioid prescribing, but was associated with a small decline in all opioid overdoses, primarily driven by a decline in synthetic opioids. But these, if you notice, these are really small effects, and they are all bordering one. So it really calls into question the extent to which these are robust effects, robust findings. So I've given you a huge range of information, but let me put it all together. In the United States at the current time, opioid overdoses pose a huge and ever-increasing problem. And the profile of this problem is really shifting across waves and has even become more of a problem after COVID or during COVID. Racially minoritized communities are a particularly increased risk of overdose, and we really need to understand why and how we can respond to this. A lot of the current solutions have focused on restricting the supply of opioids, preventing overdoses, and increasing access to treatment. And we found that restricting the prescription opioid supply may indeed reduce high-risk opioid prescribing and overdoses involving prescription opioids, but it could have these unintended consequences on the illegal opiate market. In contrast, encouraging overdose reporting and encouraging access to evidence-based treatment seem to offer cross-cutting benefits in terms of declining overdose rates. At the same time, there's this question about cannabis, and from our data, we see a small decline in overdoses associated with legalization of recreational cannabis. That is the most expansive access to cannabis. But the small effect size and the lack of impact of recreational cannabis legalization on opioid prescribing, to me, calls into question the robustness of those findings and really suggests that we need to look into that further and to look into the role of confounding by co-occurring policies further. So just at a broader level, I think the implication of these findings are, first of all, that policies that restrict the opioid supply have probably limited beneficial impact right now in the current phase of the crisis. That is, they had an important impact in the first wave, where overdoses were really driven by prescription opioids. But now we're in a wave where overdoses are really driven by the illegal market. And so policy responses that focus on prescription opioids are not really going to cut it. And they may have these unintended consequences. And at the same time, supply side strategies focusing on cannabis legalization may also not be driving a decline in overdose deaths. So what should be priorities for action? I think there's a real potential for overdose prevention strategies like Good Samaritan Laws, but also other types of overdose prevention strategies like safe supply and safe consumption spaces for people who use drugs. And also the other huge priority really is around increasing availability and access to treatment for opioid use disorder. At the same time, I really think that there's a need to move beyond this very drug-specific focus of our response and to think a little broader and think about what are some of the underlying determinants of the rise in opioid misuse. And so that to me calls into attention the importance of early intervention efforts and really horizontal prevention efforts that address a myriad of different related issues like mental health, exposure to traumatic life events in childhood and adolescence, and also to think about social and economic policies that address some of the upstream drivers of substance use, such as socioeconomic marginalization. So these are some of the areas that we are looking to do research in right now, where we're starting to do much more research, is looking at some of these broader policy responses that tackle the social drivers of drug use. Thank you very much to all my collaborators and funders.